Okay, I think we're ready. What is your job title?
Job title is Associate Veterinarian.
Okay. And how long have you been working at your current practice?
Current practice is about 5 months now.
Okay. And when did you graduate from veterinary school?
2016.
Okay. Did you do any sort of internship or residency?
No.
In the meantime? Okay, so in the time between when you graduated and where you're working now, what were you doing?
So I worked as a general practice veterinarian for a year at one practice, then did 3 months of emergency full-time at a separate practice, and then ended up at my current practice where I'm again doing general practice, but I am also filling in emergency.
Okay, so tell me a little bit about your current practice.
So my current practice is, they do general practice, emergency, and referral. We do hospitalize, and we have doctors there 24/7.
About how many doctors?
So it's about 6 full-time, and then we have some who come in just to kind of fill in some like emergency role gaps.
Okay. Tell me a little bit about your job. Like, what does a typical day look like?
A typical day is starts around 9 a.m. I usually get in a little bit early just to make sure I can do some callbacks, answer any voicemails or emails that I got from clients. And then it's appointments that are every 20 minutes to half hour when I'm doing general practice. There is a procedure day, but that's just once a week where I would do surgeries, like scheduled, planned ones. And then I just see appointments all day until 8 p.m. A lot of times, if the emergency doctor who's on has to go into surgery or is getting really bogged down with cases coming in, I'll also take emergency cases, so I'll kind of fit them in along with my appointment schedule. Obviously, if I'm doing emergency, like as an actual emergency shift, that's different. I'll come in the morning, round on the hospitalized cases, do an examination, write a SOAP on them, potentially call owners and let them know how their patient is doing and what the plan is moving forward or what the plan is for the day, and then start seeing the incoming emergency cases. And that's kind of just as they come in.
Okay. So is it generally, it sounds kind of busy. Is it generally pretty busy, or is it variable depending on the day? Like, how does that work?
Very variable.
Okay.
There's some days where, if it's a slow general practice day because it's cold outside and no one wants to come.
Interesting.
Yeah, it happens. Then there can be a gap of 4 or 5 hours where I'm not doing anything.
Okay.
But then certainly, if it's like a holiday like it was President's Day, I mean, the whole general practice schedule is full. Everyone's bringing their pets in for emergencies. Now I'm seeing emergencies on top of it. I mean, it was nonstop.
Okay. Think about the last time that you prescribed antibiotics to an animal, and then can you walk me through the process of sort of how you decided to prescribe, prescribing, and then how the drug actually was dispensed to the client?
Interesting. I say interesting because would topical ear medications with antibiotics count, or do you specifically mean like oral systemic?
Whatever you think is kind of relevant.
Okay, because the most recent one that
and why do you bring up that as a distinction?
Yeah, so I bring that up as a distinction because technically it's an antibiotic. Mm-hmm. But I think when most people say, oh, when did you last use antibiotics, you don't think of like a topical cream with an antibiotic or an eye ointment or an ear ointment. You think of, oh, I gave them, some Clavamox that they gave by mouth. So that's why I was being specific.
Yeah. Maybe let's do both, because it sounds like there might be a difference there, and that might be...
Yeah. So, I didn't have any oral cases very recently.
Okay.
At least for the last week. But I have been getting a lot of ear infections in with the weather change that's been going on. So I had a case where a dog came in, had really irritated ears, but the ears didn't have a horrible infection yet. There was definitely some bacteria, there was definitely some yeast, but it wasn't as bad as I've seen some ears look when they're that irritated.
And how did you know?
We did the ear cytology.
Okay.
And looked under the microscope. We don't do the gram stain, so I don't know gram positive, gram negative. I just know cocci or rods. And I had only seen cocci, and the truth is our practice really only carries 2 ear medication options in-house. We have Mometamax and we have Osurnia. And so this owner can't medicate at home, so I couldn't give him the Mometamax because that's something that he would have to be putting in the ears himself. So instead we cleaned out the ears a little bit and then applied the Osurnia, which you would apply now in a week, and then it's supposed to have sort of an effect for a month. And so the plan is to recheck with an ear cytology to see how it's progressing or improving 3 weeks from the first dose.
Okay. So in terms of that decision, was there a specific thing that drove you to decide to use that antibiotic? Was it the ear infection? Was it the cytology? What kind of factored into that decision?
Right. So something that I'm trying to see if I can change, but I don't know that I'll be able to, is we don't have an option for just a yeast infection or just a bacterial infection. All I've got is Mometamax, which has an antifungal, an antibacterial, and a steroid, or Osurnia, which has different medications, but the same thing, an antifungal, an antibacterial, and a steroid. So they both have the same thing in it. So in terms of coverage, they're both going to be the same. The difference really comes down to what does the owner want to pay, because one's more expensive, and can the owner apply the medications at home by themselves? Because if they can't, they just have to come in for 2 dosings at the hospital, and it's a lot easier for them.
Okay.
So...
And was there a particular reason that this is difficult for owners to apply the
just because,
other drug?
Yeah, when they have to put drops in the ears, and the dogs will freak out. Some of them will bite, because their ears are really sensitive still. And once their ears feel better, they might let them, but not in those initial stages. And if they're not getting the medicine, it's not doing what it needs to do. So.
Yeah. So I guess, is there any difference in how that process works when you do prescribe something oral? You kind of mentioned there's a difference.
So it's different when I'm doing an oral medication because I certainly have a lot more options.
Okay.
It's not just 2 drugs. And when the 2 drugs, it's not a difference of how they're given or anything. Like, they're all going to be given orally. It might be once a day or twice a day, but besides that, I can focus more on coverage. So I when I'm doing an oral medication, I can focus more on where I think the potential infection is, what kind of infection I think would be there, what antibiotic I think is going to cover that.
Can you give me an example of
a recent time? So a specific example is a hot spot.
Okay.
So if a dog comes in with a hot spot, generally it's like a moist dermatitis and it looks really infected and nasty. And so we'll clip it up, clean it. Honestly, I used to do cytologies to see what I saw. I don't anymore. Reason being, I have not had a time where it changed my medication choice.
Okay.
And they just happen so often, and the cytology is like $50, and most people would want to decline it anyway. And so you end up treating, and then if for some reason, which I've never had it happen, to be honest, if it doesn't get better, then you say, okay, now we need to, either do a cytology or a culture and see where that gets us. I do try to warn people, I don't know what's going on here, but it's probably going to respond so that they know. But But yeah, I don't do cytologies on them anymore. So with the hot spot, we'll scrub it with a chlorhexidine, and then we'll give them, I pretty much always do Simplicef. The reason for that over like something like cephalexin is that it's once a day, and so I feel like I get a lot more owner compliance out of it. It has the coverage against the bacteria that I see on a normal skin surface that might then be the source of infection.
Is that broad or narrow or
broader?
Okay.
I'll be honest, I don't remember what ones it covers, but I know it gets like my staph and stuff, which are bacteria that are normally found on the skin. So I know that's where the knowledge comes from. I just forget some of the details. And I know cephalexin could be another good choice, but it's twice a day, and I just, if I can give something once a day, why not?
Yeah. Is that something that owners have specifically like asked for a lot, or is it something at this point you just know like? Yeah,
it's kind of more that it's one of those things where I think many of the habits that I've acquired for antibiotic usage were based on what I saw doctors using based on their experience. And, you know, I would ask them why. It's not like I just said, oh, they're using it, so I'm going to use it. I would say, you know, why are you picking this one over this one? And they would say, oh, because it's got, you know, good coverage for bacteria you'd see on the skin because it's only once a day. And I'd say that makes a lot of sense. And then I would kind of take that in. So, you know, it's not like every time I would see a hot spot or, you know, just a simple little laceration or something, and I'd have to go through the whole, like, okay, what could be there, blah, blah, blah. All it's just, I'd go back to what I originally learned when I started.
Yeah.
And it's, so far, it's, knock on wood, it's worked. I haven't really had any major problems.
So can you talk to me about a time when it was difficult to decide whether or not to prescribe an antibiotic or which antibiotic to prescribe, and kind of what made that decision difficult, and then how did you ultimately make the decision?
I think there's sort of two situations where I run into that. One is when I haven't proven that there's really an infection yet, and so then I don't know whether I should be preemptively using antibiotics just in case, or whether that's bad medicine. So like the Schnauzer that I had that came in with evidence of renal failure. And there was some other stuff going on with it, but, you know, it was potentially a lepto suspect, but there weren't really any liver elevations with it. It was a potential pyelonephritis, but I didn't see any obvious infection in the urine, but it was also really dilute, so you might miss it. And so I didn't know whether I should just be throwing antibiotics at it or waiting till I had, you know, some sort of results from something. And other people were saying, no, you just start them on it because you can't wait to get a lepto response back or a urine culture back in days.
Yeah. So you asked other people at your practice? Or?
Yeah. I ended up going to other people at my practice to get kind of their thoughts. I usually go to the specialists if they're available. Otherwise, it's just whatever doctor is there. And they recommended starting on the antibiotic because the negative of starting an antibiotic is less than the negative of not starting it if there's really an infectious problem. The other case is when an owner wants it, and I don't necessarily think they need it. And I definitely had that recently, where I had a cat come in. Owner says twice a year or so, the cat gets an upper respiratory infection and needs antibiotics. And I felt as if, one, it was very mild. There wasn't a lot of, like, goopy yellow or green discharge. It was just kind of a serous discharge from the eyes, a little bit from the nose, and it was wheezing. And I explained to him, this is probably just a reoccurrence of a viral infection, and it's really not getting in bacterial infection, and you don't need the antibiotics. I was like, you should probably just try something like a Zyrtec or whatever, or even, in case it's an allergy, in case it's a seasonal thing, and more than just a virus. But other than that, just monitor. And if it doesn't become a bacterial, then you don't need it, and you're using it unnecessarily.
Yeah.
And the guy seemed interested. He wanted the antibiotics this time, but I gave him like a Zyrtec dose and explained it to him, and he said, he might try the Zyrtec first, or next time he'll try it first, or something. So I don't.
So did he get the antibiotics too?
He did. He
Okay.
did. I tried to sort of talk him out of it, but he had clearly gotten used to a system where he walked in, said, I want antibiotics, and people said, okay.
Yeah.
So that's what he wanted. He seemed to listen. I don't know what he'll do next time. So
Yeah. And he still, so you guys dispense the drugs from your clinic as well, or?
Correct.
Okay.
Yeah.
And does he usually see other doctors at your practice?
He
like
had,
how did this history, do you think, happen?
so he had been going other places.
Okay.
He had only come to us as an emergency for his other cat,
Okay.
who got a huge open wound on her hind end that I had to manage. And so then I guess he decided to bring his other cat into us as well and started using us as his primary also.
Mm-hmm.
And that's how I ended up seeing his cat. So it was some other primary
Yeah.
that had just been giving him Clavamox, and that's what he was used to. And that happens a lot. Like, there's honestly a lot of cats with reoccurring, I don't even really know that you could call it a URI, because
Mm-hmm.
I don't think it's really, like, a new infection.
Yeah.
And it's just easier sometimes to get them out the door if you give them the antibiotic, because they think they need it.
Yeah. And in that case, do they ask for like specific antibiotics by name, or how do you decide what to give them?
So
If
in
you're
general,
really kind of not on board.
in general, they usually probably end up getting Clavamox, I would guess,
Mm-hmm.
because that's what I give. And the reason being that Clavamox does a really good job with getting, like, if there was an upper respiratory infection, it has really good coverage for that, and I've seen it do a good job when there's a real one. So it's the one that everybody always gives. And the truth is, you could give them like a sugar pill, and if you told them it was, this is medication Zardu, they'd come in asking for Zardu every time, because they're like, it worked last time.
Sorry about that.
It's okay. They're like, it worked last time, so I want it again.
Yeah.
Is the idea. So I don't think it's that they know that it's a drug that's working, or that the drug necessarily did anything. I think it's that they thought it was what made the difference last time, so they want it again.
Okay. And you say you see this pretty frequently.
I
Is it
mean-
mostly with cats, or is there other types of things that this happens over and over again?
I would say it's mostly with cats. It's not like all the time, but it's certainly something that I would say happens, a couple times a year.
Okay.
It's something that I'm familiar with, but at least in this practice, I'm not seeing it constantly.
Yeah.
It does kind of happen with kennel cough too,
Okay.
where they'll come in and they have this horrible sounding cough, and the owner just wants to give them something.
Yeah.
And I kind of have issues giving them cough suppressants, because if it's a viral infection, the cough is to get it out, and if they're not coughing, then they're not getting it out, kind of a thing.
Yeah.
So it's hard. I try to tell them it's just a matter of time,
Yeah.
but a lot of people just want a medication, so
And in that case, is there a specific one?
probably Clavamox with that too.
Yeah. Okay. So you already talked about some of the factors that kind of impact antibiotic decision making. I think you mentioned a little bit, you do cytology and figure out what the results of that are.
Right.
It seems like, and correct me if I'm wrong, I'm just trying to summarize here, that sometimes the ability of the client to give the drug to the animal is a factor. I think you mentioned, at least with the ear infection drugs, that what you have in your pharmacy is a little bit of a factor in what the animal gets. And that you mentioned a little bit that cost kind of factors into at least your decision on whether or not to do a cytology.
Yeah, or even a culture.
Yeah. So can you talk to a little bit about like what other? Oh, and obviously clients expecting getting drugs. Are there any other factors that kind of play into this issue that impact your prescribing?
Yeah. So what we have available, what the owner's willing to pay for in terms of testing, so that we know what's going on, what the owner is able or willing to give in terms of medication, whether it's oral, topical, whatnot. And then, obviously the wound itself, like where it is, or what the infection, like where the infection is, where we think the problem is, and what could be there, just based on general knowledge. But then I also think experience. Like I have a good experience with Simplicef and Clavamox, and so I use those.
So I've heard other veterinarians talk about experience. What do you mean when you say experience? Like, what does that kind of boil down to? What factors into that experience?
Right. So what that means is, every time I see an infection of some kind for the first time, even if it's a laceration, but let's say it's a UTI, but this time I see rods instead of cocci. Well, that's the first time I'm seeing that. So, I'll make an educated decision about what to use, and then if it works, that's what I'm using every time I see that, unless there's another reason to do it. So it's definitely that you get in a comfort zone of what you feel works for you, and unless you're able to do a culture that tells you to do something else, you're going to use that.
Okay, that makes sense. How... You brought up culture twice now, but you didn't mention it when you were talking about sort of how you decided to prescribe for your examples. So how often does
a culture happen?
Yeah.
So...
And what kind of impacts the decision of whether or not a culture is done?
The reason that I probably don't bring it up as much in my examples, or get to use it as much, is because in a general practice setting, I feel it's less common. Reason being, let's say a respiratory issue comes in. Getting a culture sample for a respiratory issue is like a whole ordeal of like a trach wash or a BAL or, whatever you're going to have to do. And people don't want to go that route until they've tried a therapeutic trial first. So I'm always kind of making a guess for an antibiotic first. And then if that's not working and the patient is declining, or if now it's become a pneumonia instead of just, a general anything less severe, then we're going to get more aggressive. But, so I'm not doing it for a lot of my respiratory cases, at least initially. And then for like urinary tract, I will do them quite a bit if the owner will allow, which, they're $200. So owners usually aren't doing that until a therapeutic trial has failed.
Yeah.
So urinary tract, I do it sometimes. And then for a wound, I always try to push people to do it because I don't know what's going on in that wound, or if we don't know where the wound came from, or if it was a bite wound and we don't know what other kind of stuff could have gotten in there, and we're worried about abscess and stuff. I always try to push them to do it, but I also see a lot less lacerations and bite wounds than the emergency doctor.
Okay.
So.
And so you mentioned $200 for the urine bacteria culture. Is it kind of the same for the others, or I guess the respiratory one, getting it is part of that?
Oh, yeah, because you have to do, it's like a whole anesthetic procedure, to do that. Getting a culture sample for a respiratory is very expensive and intensive, and you're usually not doing it unless other therapies have failed, at least in what cases I've seen.
Yeah.
But, yeah, so that's intensive. With the urine culture is definitely like $200. Then you have the cultures where it's like, do you want aerobic versus anaerobic versus aerobic and anaerobic? And so that's an interesting thing that I guess, like, I often don't know which one I should be picking.
Okay.
I often don't. Because I'll assume if it's something in the lungs, it's got to be aerobic. It's in the lungs. But there's totally anaerobic infections that happen in the lungs. And then what if you miss it?
Yeah.
And then in the urinary tract, I'm like, oh, it's got to be anaerobic. It's in the urinary tract. But the truth is, it's usually an aerobic because it was an ascending infection from the outside. So I'm always so worried that I'm not going to think of a bacterial infection that could have happened. That's that I just do aerobic and anaerobic every time.
Yeah.
Which obviously makes it more expensive.
Do you know how much that costs generally?
I don't, unfortunately.
Okay. Yeah. And I guess in general terms, how does the cost of testing compare to the cost of whatever antibiotic treatment you end up doing?
Right. So
anyway.
What I can say is that aerobic and anaerobic is probably it's got to be around $250 or something. It's not like it's hundreds of dollars more.
So compared to giving them antibiotics and
right. So compared to giving them antibiotics, it depends on the antibiotic and how long of a course I need to do. Doing the cytology on a hot spot, it's going to be $50-$60. But giving them the Simplicef is going to be $50 or $60. So usually they just go for the antibiotic. Mm-hmm. However, if we're talking about Lyme disease and using doxycycline, I'm encouraging people to do the 40X and the Quant C6 testing, because that doxycycline, if it's a bigger dog, can be $300.
Okay.
So it depends on the antibiotic.
Yeah.
And it definitely affects how much I say, look, we really should figure out, because otherwise you're going to be in the hole and we're still not going to have an answer.
Based on what you said, when you talk to clients, it sounds like you're giving them choices.
Yeah.
Do you generally present them as choices, or do you say, this is what we would like to do? How do you talk to a client about these, what you want to do?
Right. So I always try to approach it as, I go in, I tell them what I think is going on and the problems that I see and the problems that they're reporting, and say, to figure this out in a best medical care fashion, I need to do 1, 2, and 3. And I'll explain why I'm doing 1, 2, and 3 and how that's going to change my treatment plan. A lot of times they can't do them all. And so I'll say, look, that I need to tell you what your options are. I need you to not leave here and go, well, I didn't know that was an option. So I have to tell you that, but I totally understand that you can't do that. So I do have 2 other potential options for you. We can skip 3 and just do 1 and 2, but that means we might miss something, and that might change the treatment plan, or might mean that you have to come back and spend more money later to get this fixed. We can also just do 1 and make an educated guess and skip 2 and 3, but then there's, this chance of this complication, or this could progress and make it worse, and then we're looking at more money down the line. Mm-hmm. So I try to make it really clear to them, you're not a bad person for choosing something less, because sometimes you just don't have the money, but you do have to have a full awareness of the potential repercussions of doing that.
Yeah.
Because I don't want you coming back here and saying, well, had I known.
Yeah, so there's a lot of kind of discussion between you and the client about options and finances that's kind of wrapped up into the decisions that are
very much so.
Okay.
Yeah.
So how do you view your own prescribing levels and patterns in relation to other people, other veterinarians?
I think I started out very equivalent with the average person that I was working with, at least. Mm-hmm. I have tried to work more in a direction of not just giving out antibiotics. I have tried to have those discussions with owners about, this is, kennel cough. They're not showing any signs of a bacterial infection right now. We took an x-ray of their chest, and there's no evidence of anything going on in their chest. This is just something that they need to get over. Or this is just, a viral infection causing your cat to have goopy eyes, Mm-hmm. So I at least have started trying to really have those discussions to avoid unnecessary antibiotic use and unnecessary spending and medicating by the owner. And I have also caught myself kind of asking, well, do I need to really use antibiotics here? I think a really big one that I've learned about that I've really tried to cut back on is metronidazole. Everyone likes to throw that at anything with diarrhea. And literally, I didn't realize until this past year that's really not necessary, especially in mild cases. And so I've been just switching to a probiotic and a bland diet, and it's working, and owners haven't been upset about it because it's been working. I totally didn't realize that, so I've been cutting back on that.
I think you answered. I was going to ask if your prescribing patterns have changed over time.
Yeah.
So, unless you have anything else to say about that, how do you get new information, or do you get new information about antimicrobials?
So that's the big problem that I've been having, is I don't really have a lot of great ways, at least I feel, to get that information. Mm-hmm. I try to read up on Clinician's Brief. I try to sign up for like the Internal Medicine, journal and read that every once in a while. It's hard to keep up with it all. Mm-hmm. Is the problem that I'm having, and so I feel like I'm sifting through a lot of information to try to get to things that might be more clinically relevant for me on a day-to-day basis. Probably my biggest source of information are just the doctors around me, and asking them, what they would use or what they would recommend, or what they would avoid, why, mm-hmm. And trying to learn from that. I've asked multiple doctors, where did you get your information? How do you know all of this? How do I get there? And honestly, they just say you have to go case by case. If you have a case that comes in with a pneumonia that's not responding to the drugs that you experience-wise have decided to use, then you end up doing a bunch of, crazy research looking into what other things might be going around these days and mm-hmm. adjusting as you find information.
So do you have like a general reference or something that you use when you're trying to figure out which drug or dosing or anything, or is that kind of just from your experience in vet school? Or?
So I made an Excel sheet of antibiotics and pulled drug dosing from both Plum's experience, VIN, and tried to kind of find a middle road between them all.
VIN is?
Like Veterinary Information Network. Okay. Yeah.
I just wanted to have that.
Yeah, that's fine. And I think the biggest variation that I've seen, more than drug dosing, everybody seems to kind of agree on the dosing. Mm-hmm. The thing that I've seen people totally all over the place about is how long. Oh, 7 days, just kidding, 10 days, just kidding, 14 days, oh, maybe like 3 weeks. I feel like a lot of times it's a little guessing with that.
Have you had some other people have mentioned CE, or I know when I was in practice as a tech, sometimes pharmaceutical reps would come, but I don't know if they do antibiotics stuff. Have you had any experience with that?
I haven't had any reps come in and talk about antibiotics, but I'd kind of love it. And I just went to VMX, and
which is
the North American Veterinary Conference that they changed to VMX.
That's fine. It's a conference.
Yes, a conference. And when I was there, I specifically was trying to go to dermatology-focused lectures because I like dermatology and I wanted to know more about it. I did also go to one about respiratory disease and trying to understand the antibiotic usage there. So I was trying, mm-hmm. and the respiratory one was actually very helpful because it did go over antibiotics that they recommended for different kinds of cases. But again, I think it was just very experience-based or based on research that she had done. And so for these cases, that's how she handled them, right? But that's, I'm sure, going to change over time. Mm-hmm. And we'll just have to see what that means. But for the dermatology ones, they were just like, here's every drug that exists. And you're like, but what ones should I be using and when? So they would just list everything, mm-hmm. all the topicals, everything, and I was like, but what one is better for what cases? When should I skip over one thing? When am I overusing something, mm-hmm. And they just weren't telling us that.
Yeah, so I guess in your ideal world, what would be helpful? Or would it even be helpful to have more information on this?
I think, so more than and I don't know, I could be stupid about this, but more than telling me what does work, I almost wish they were telling us what they're seeing people doing that's a failure. Like, I wish specialists, like internal medicine specialists or dermatologists or whoever sees these cases when they've been mishandled, essentially. I wish they were coming to us saying, you guys are all using Mometamax all the time, and instead we're getting these crazy, resistant bacteria in the ears because half the time it's just yeast and you shouldn't be using it or something. You know what I mean?
Yeah.
Like, that's what I wish there was. Like, I wish there was someone out there telling me, why are you using metronidazole? That's a waste of time. It's unbelievable to me that I didn't hear that until like a year and a half out of vet school. When I was in vet school, everything was on metronidazole. I don't know if that was because they were all really critical cases and they were in a tertiary referral facility, or that was just that doctor's preference. But I saw metronidazole in every GI upset case that was there. And so then I felt that that was a reasonable thing to do. And then when I went to work at my first practice, everybody used it. And it wasn't until I talked to a critical care specialist that I realized that there's really just not a point. And until I started trying it out and realizing, you're right, there's not a point. It's just not necessary. So I wish that I was learning more about what we're doing wrong, because there's too many options out there that are right.
So do you feel that there's a need to improve the use of antibiotics in companion animal veterinary medicine?
Oh,
I mean,
definitely.
it sounds like,
Definitely, yeah.
And so what do you think are the barriers to using antibiotics appropriately?
I would say stocking in the hospital and owners.
Okay.
If I don't have it, I can't use it, and if the owner's not going to let me pay for the testing or get him on a certain medication, then there's nothing I can do.
Yeah. Do you feel like improving antibiotic use is an important goal at your practice?
No.
Okay. Do you want to elaborate a little bit? Or?
I mean, I asked about getting a medication for just yeast infections on purpose. And they were like, when was the last time you saw an infection that was just yeast? And I was like, that's valid. I'm probably seeing, only like a quarter of my ear cases are just yeast. So they're not very frequent. And they were like, I just can't justify in the budget having that for, 10 cases a year.
Yeah.
We'll just use the one with the antibiotic.
Can you prescribe to outside pharmacies? Is that an option?
I can, and that's something that they brought up to me that I honestly hadn't considered. So I might start thinking about that, but the truth is an owner comes in and they want to leave with the medication and they want to be done with it.
Yeah.
So in most cases, I'm sure someone's going to be like, can't you just give me something here? I'm going to try to do that, but it takes me remembering it. It takes more time because I've got to go get a script and I have to do it rather than being like, okay, nurse, you've got it. Go get the meds and get them out of here, kind of a thing. So it's just a lot more effort, and I'm not even sure that the owner's going to care.
Yeah. You mentioned time now, and it didn't come up earlier. Is time kind of a factor in this at all, or is that usually not too big of a deal?
I mean, it's not if I'm not scripting stuff out. If it's stuff in the hospital, choosing this medication or this medication isn't really a huge difference. I mean, if I'm doing Mometamax, I just send them out the door. If I'm doing Osurnia, it takes a couple of technicians to clean out the ears and give the med. But in general, that has never made an impact on me choosing what medication to use. And I've never felt any push by technicians or anybody else to, oh God, please don't make us do Osurnia or anything like that. So no, but if I'm trying to research what options are out there, where the owner can get it, scripting it out, that's going to take a lot of time.
So do you think antimicrobial resistance is a problem sort of in your practice? Have you seen that as an issue?
Actually, yeah. When I first started there, we had two. It was not MRSA because it was pseudo-intermedius. It was staph pseudo-intermedius. So MRSA. We had two of them. They were, honestly, it was right when I started. so I don't remember the whole history of the cases, but we started getting really worried because we were like, oh my God, we've now had 2. They'd come in for laceration repairs or bite wounds. It was like something along those lines where they had a surgical repair of something and then developed the multi-resistant staph pseudointermedius. And we had cultured and found it on both of them. And then we're trying to manage it with regular bandage changes, a change in the antibiotic use. And I think both of those cases turned out to be okay, as far as I know. I didn't hear anything bad, and they looked like they were getting better when I did see them in the hospital. But we definitely had a couple of cases.
And do you think it's an issue for veterinarians in general? Do you think it's changing over time or really an issue?
Not really. I mean, look, I say not really, but that's from like a small bubble, right? I mean, I went to this one practice and they had 2 problems right after the other. But then I haven't seen another problem since. We've certainly continued to do surgeries. We've done laceration repairs, and we have had, no issues with it. So, at least in my cases or the cases that I've seen, I haven't seen a major problem with it. But I think what scares me is that when it's a problem, it's really scary.
Yeah.
So it's one of those things where it's it's sort of like telling people to vaccinate, right? Well, not every dog that's not vaccinated gets parvo, but when they do, it's horrible. Yeah. So let's prevent it.
Yeah.
So I think it's one of those kinds of things.
And how do you feel about antibiotic resistance in human medicine?
That I feel like is a lot more prevalent. Because I definitely hear about it a lot more. It seems like I've definitely heard them say my grandfather was in the hospital and they were like, yeah, we want to just get him out because otherwise he'll probably get a multi-resistant infection. And that's horrifying. Yeah. That they're sending people out maybe a little earlier than they need to be just to protect them from the hospital.
So kind of linking to that, what can be done, or what do you think should be done, either at the practice level, at the veterinary medicine level, or at human hospitals included, to address antimicrobial resistance, if anything?
I think there probably needs to be some sort of review or reminder of what makes an antibiotic necessary, because certainly, when you have the flu going around or the colds, and everybody's like, I want an antibiotic, and then the doctors all give them antibiotic. I went to a doctor for my cold, and they were like, do you want antibiotics? And I was like, I don't really think I have a bacterial infection, and I went on steroids and I got better. I mean, I think I needed a boost, but I didn't have a bacterial infection. And also, you can still get, even if you have a bacterial infection, if it's not horrible, you could still get better. It might just take a little bit longer. And I think we just need to start prioritizing a little bit and reminding people how to do that. Because I think a lot of, you're not going to be able to tell every owner this is when they need antibiotics and this is when they don't, because then they're going to start playing doctor. But on top of it, you're just not going to be able to reach them all. So you have to make the veterinarians care about it, and you have to make the veterinarians confident. Because I think the biggest problem I have is when an owner sits down and says, I want antibiotics, I have trouble saying no, because I'm like, what if I'm wrong? And they should be on antibiotics. And then I'm the reason that their pet gets worse, and they have to come for a second visit.
Okay. Anything else you'd like to add?
So I'll tell you that story. So when I was at the conference, I was talking to this one other veterinarian, and they were saying, I don't like where I'm working. The doctor that they work for was trying to tell them what antibiotics to use for a specific case. I'll just give the person a name. So, Bob is the other veterinarian that I'm talking to. And so Bob's like, yeah, my boss wants me to use this other drug for this case. And I was talking to them, and I was like, you don't even know the method of action. You don't know, what its coverage is, and it shouldn't be used in this case. And he was listing like all the mechanisms of action and the specific gram-positive or gram-negative coverage of this one antibiotic his boss wanted him to use, and I realized I didn't know any of it. Like, I didn't know any of that. So, like, was I making the wrong antibiotic choices? Like, so that was a little eye-opening in the sense that I realized that a lot of my antibiotic choices come more from experience and talking to other people than it does understanding true mechanism of action. And I don't know if that's wrong.
This might be a weird question. I'm not sure how to phrase it, but why do you think you don't understand the mechanisms of action?
There's just too much to know, and I get confused. When I can look through a list of antibiotics and it'll say this one has some gram-positive but some gram-negative, but not really this one, and not Pseudomonas, and you just get them all confused.
Okay. Anything else?
No, that's it.
Okay. Thank you very much.